Thanks, Andrea. Hello, everyone. Thanks for joining us this afternoon for our presentation where we plan on discussing the project we've been undertaking. My name is Dan. I'm here alongside my colleague, Aoife, and we've been conducting and managing this project together. So, as Andrea mentioned, we are clinical teaching fellows based in Nottingham across a couple of hospital sites. So as well as delivering teaching for our students, we're also involved in the development of and the improvement of the course locally. So our project was improving the teaching specifically in VTE for medical students in order to better prepare them to manage the condition when they go on to see it in the next couple of years in clinical practice.
Brilliant. So why did we choose this project? So firstly, as part of the AP1 curriculum, so for those of you who don't work in the University of Nottingham or University of Lincoln, that's essentially the equivalent to fourth year medical students. Essentially in that year, they have a haematology week. And in that week, when they come to us on placement, basically a gap became available in the teaching schedule. So we as the CTFs, most of whom are junior doctors or resident doctors, felt that we could fill this gap as opposed to needing to utilise consultants and take them away from clinical time. So we wanted to find a topic that we felt comfortable teaching and was something that we felt that we had genuinely experienced quite a bit of in clinical practice. So this is why we thought VTE would be a good topic for this. So as the previous presentation has just covered, VTE, i.e. DVT and PE, is really quite a common thing to come across. So just as a reminder of that and reiterating some of the statistics in the previous presentation, according to NICE CKS, it presents symptomatically in about 1 to 2 per 1,000 patients annually. And in those who are critically ill, actually, it's been reported as an incidence of up to 37%. So, you know, if we're thinking about foundation years, this is going to crop up time and time again for you, let alone if you're thinking about over the entirety of an entire career. So it makes this topic really relevant for new graduates, and so hopefully in turn would increase patient safety if we give them a good basis of knowledge. Also, for those of you who are involved in education, you'll be aware that the curriculum has kind of shifted towards the MLA. So that's the medical licensing exam, which is basically a standardised national exam which all final years have to sit. So if I just take you on to the next slide, as you can see, so for those of you who've seen the MLA handbook before, this is the kind of structure that it looks like. But as you can see, under clinical haematology, VTE, i.e. pulmonary embolism, and deep vein thrombosis represents 2 of the 20 required conditions. They're also, in our opinion, topics that probably most junior doctors would be better placed to teach as compared to some of the more specialist conditions on this list that some of the consultants' knowledge and experience of would be really, really valuable for the students. So essentially, after all of that information, we basically still needed to ascertain if the medical students also perceived this to be a gap in their learning. And so whether utilising this new gap in their teaching programme for that week would actually be worthwhile. And so that's why we decided to pursue this project.
Okay, thank you. So what was the main overriding aim and the objective of our project? So the main aim, as per the title, was effectively to improve the VTE teaching for medical students in order to better prepare them to manage a condition when they see it in clinical practice. And to do that, we had a series of objectives. So firstly, we wanted to highlight the medical students' perceived weaknesses and knowledge gaps on the topic of VTE. So we were thinking about perhaps doing a small quiz in order to ascertain exactly how what their knowledge was on the subject, but we didn't want to add to their burden. We wanted to simply ask them whether they felt they were well prepared to manage these conditions and identify which areas they felt were most weak within the topic of VTE. We then wanted to determine the best method for addressing these areas. And then once we've done that, we were going to design and implement a teaching program in order to improve their competence and confidence in this area. So we'll briefly talk about the methods of our project. So we surveyed effectively the medical students in the region of the East Midlands. So we mostly did this online, but a few paper forms as well. We sent our surveys out across 6 different hospitals, including the 3 counties of Derbyshire, Nottinghamshire, and Lincolnshire. And this included 2 different medical schools. And in total, we asked students specifically who have just finished a haematology placement. So these are students that should be relatively well versed on the topic, and they should have just recently received their teaching on the area. In total, we got 68 responses, and then we had a look at the data and analysed it from there. So talking through the results. So some of the questions we asked, the first question was, to what extent was this topic covered? So if you look at the pie chart on your screens, the biggest block, the first block, so if you go from 12 o'clock onwards, 38% of respondents said that this was not covered at all, which is quite an alarming statistic. We know how much it is associated with morbidity and mortality. We know how high the frequency of VTE is in clinical practice. And the fact that junior resident doctors do deal with it every single day, even if that's just prescribing prophylactic enoxaparin or low molecular weight heparin. So for 38% of students to say it was not covered in their haematology teaching was quite a shocking statistic for us. Going onwards, another 38% said, sorry, 35% said, yes, it was taught, but only briefly. So now we've got a situation in which almost 3/4 of all medical students said that they weren't really covering this topic in any great deal at all during the haematology teaching. So of course we wanted to try and improve this and do something about it. As the pie chart goes on, 19% somewhat, 8% well, and absolutely no one in all the respondents said this was extensively covered. So definitely a lot of room for improvement and definitely a hole in the market for our teaching. And then we simply asked them, how would you like the content to be covered? So we directly asked them because by this stage of medical school, as Eva mentioned, it is effectively fourth year students. Most of them know how they're best learned. The majority of them said tutorial. So a small group tutorial, and it's more of a conversational based, where you can do some teaching. They can come back at any queries that they've got. A few people said lecture, and then we've got case-based discussion as well, which, as we'll come on to later on in the presentation, we've incorporated into our tutorial.
Okay, so back to me. Moving on now to discuss our free text question. So this was where we basically asked the students what they currently found most challenging about the topic. And so therefore it's ascertaining their perceived weaknesses on the topic. So for this portion of the data, i.e. the qualitative analysis that we performed, we utilised a common methodology called thematic analysis. So this basically involves reading and understanding before interpreting your data. Then basically utilising that understanding and knowledge to turn poignant parts of the data into codes, and then you subsequently identify the main overarching and umbrella terms, which are known as themes within this kind of analysis. So these are basically themes and terms that repeatedly emerge from the data. So talking about the slide that I've put in front of you, these were the common themes that emerged, and so I'm going to take you through them one by one now. Okay, so the first of these themes we basically titled diagnostic uncertainty. So this basically covered any of the students' queries and knowledge gaps surrounding barriers to them successfully diagnosing or identifying VTE. So many of the responses did actually focus largely on DVT as opposed to PE, but I've put some examples anyway of some of the quotations that I think quite nicely displays diagnostic uncertainty there and what they kind of are struggling with. So just to read them out to you, basically it's the first of them said people struggled with recognizing the more subtle signs of DVT. And then the other one is distinguishing between DVT and cellulitis. So again, you know, really highlighting that actually maybe if their knowledge on DVT wasn't super hot, they might not actually be able to understand the differences or the nuances of those conditions in clinical practice, essentially. If I move you on to the next theme, which continued to emerge from the data, this is the Wells criteria, which is, you know, something that we really commonly use in both PE and DVT. So as part of the Wells criteria, for those of you who are clinicians or who are familiar with the Wells criteria, one of the questions is that you get negative points in the Wells criteria if another diagnosis is just as likely. So this kind of ties into that diagnostic uncertainty again. And I think people were getting very confused from the responses that we read about when a diagnosis would be just as likely if they weren't sure what the diagnosis was in the first place, and they were trying to apply the Wells criteria to be able to differentiate those things. So, you know, we could target that in our teaching session as well to try and iron out some of those creases. The other thing that people struggled with was actually calculating the well score itself. So I don't know about you guys or how often you use the well score, but I always go back to like MD Calc and use a calculator on there just so everything's displayed out for me. I would never have to do it in my head, but I think students sometimes get a bit stressed about having to do this. So I think we hoped that in our teaching session, again, we would incorporate some patient presentations where you'd have enough information to calculate a well score and just get them used to plugging those numbers into the calculator and then being able to utilize that score. Kind of very closely tying in with both of those first two, the next theme was investigation selection. So, you know, as well as the well score, there are lots of other investigations that are involved in VTE, be that DVT or PE. So people had said they weren't sure when to do the D-dimer, when they weren't sure of the diagnosis. So again, it's this repeated theme of diagnostic uncertainty, but then taking it one step further to then not knowing how to use the investigations that they know are related to this topic in the appropriate way. So again, wanting to iron that out in our teaching session. The second quotation, just again to highlight this uncertainty with investigation selection, is D-dimer and well score, where do these fit in with CTPA, VQ scans and Dopplers? So again, really wanting to knuckle down with the investigations that are available to the students and when you would appropriately apply them.
Okay, so moving on to the next three key themes in the results. So going on from investigations and diagnosis, management. So there was a general understanding that management would generally involve some sort of anticoagulation. And again, with medical students with anticoagulation, they were aware of the fact that there were some contraindications. They wanted to know how to manage it, yes, but also how to manage it when there's some contraindications to using blood thinners and the risks that could be involved with that. Following on from that, if patients are already taking an anticoagulant, whether it's a DOAC or warfarin, if they were to get a further VTE, how would we manage the situation in that case? And also the duration of treatment. So again, there was a general understanding that treatment could be for a set period of time, for example, 3 months. But equally, the students were able to say that, for example, some patients are taking anticoagulation lifelong for a VTE. And why is that the case? And obviously we'll go on to sort of speak about unprovoked versus provoked PEs and how we sort of diagnose the difference between that and how that feeds into the duration of treatment. And then the last two areas, I guess, is where we sort of come in and try to improve this teaching. So clinical exposure. So the first point there, haven't seen any DVTs in real life, nothing to compare to. So how are we expecting our students to successfully and confidently diagnose VTE if they've not seen a DVT on the ward? And some presentations might be different or not that obvious. So again, one of the common themes was differentiating between perhaps a cellulitis and a DVT. They may have seen a few cellulitis on the ward. They may be aware of the fact that there is some overlap in terms of the signs they do see. But if they've not seen a DVT and we're not taking them onto the wards in order to see them, how will we expect them to do that? So that's something that we definitely need to think about increasing their clinical exposure. And then finally, formal teaching. We asked them what type of teaching they want, and in their pros comments, they also mentioned that they thought teaching would be really useful. So the first comment, I've never been given formal teaching on this at medical school. As we can tell from our earlier pie chart, this definitely isn't in the minority. This is a very common theme that was coming out of our analysis, which we were quite surprised about. And it's such a key topic, it's such an important topic. So to never being taught this at any stage is something we really need to do better at as a group of healthcare professionals. And we're just like an in-person teaching on this. The final comment, which we were really happy to get this comment because it really justifies the whole project and thing we were trying to do. A seminar or tutorial on this would be amazing to include in the curriculum. So really justified our work and motivated us to carry it on.
Okay, so we've given you quite a bit of information there, so I'm just going to summarise all of that for you. So essentially, what our data found was there's little to no coverage of this topic in the curriculum at present. In terms of how they wanted it to be executed, they felt a tutorial would be best suited to teach this topic. And essentially, the other than wanting clinical exposure, which we can facilitate with ward-based teaching, they wanted that tutorial-based teaching to focus on, applying that knowledge to selecting correct investigations, particularly on when to apply the well score, and then the subsequent management that Dan took you through. So they were the main points that came out of our data set, essentially.
So that's effectively takes us up to today. And now we're going to briefly, right at the end, just talk about our action points, the main action points for our project. So as we mentioned, we are in the process of planning a 1-hour tutorial for students, focusing in particular on those common themes, so the investigations and the management. Yes, we're going to deliver it locally ourselves, but we also plan on reaching out regionally as well. So if you think back to that previous map earlier on in the presentation, we want to teach it at the medical schools that we sampled at effectively. So Derbyshire, Nottinghamshire and Lincolnshire as well. We're going to produce some materials and we are going to brief the facilitators to try and ensure some sort of consistency with respect to what the students are receiving at each space. And then ultimately, we're going to turn it into a quality improvement project by re-surveying the students after the session's been rolled out for a sufficient period of time, and then gather feedback, A, to make sure that they are improving and increasing their confidence, and B, just for ourselves, so we can improve it and change it if necessary for further years. And if I just direct you towards the right side of your screen, and this is just a brief lesson outline for a 1-hour tutorial that we plan on taking. So AP1 medical students, as we mentioned before, this is equivalent to 4th years outside of the local medical school on the topic of VTE. The aim of the tutorial, slightly different to the aim of the project. The aim of the tutorial is to increase knowledge and understanding of VTE. And if you look at the materials and requirements, so I'm not going to take you through each one by one, but the main part of that is the fact that there will be a clinical facilitator with some experience and confidence in the area. So whether that's a clinical teaching fellow, a ward doctor, or potentially a specialist nurse. And then we're going to provide this outline with the key discussion points. The learning objectives: define the types of VTE, understand the risk factors, recognise the clinical presentation, understand the investigations when suspecting VTE, understand the acute and the long-term management, and then appreciate the areas of complexity and the uncertainty for those higher achieving students, so they're more confident at appropriately managing it when it comes to clinical practice. The structure of the tutorial is split into 2 parts. The first part, part 1, will be the most part of the session. A brief introduction, including some definitions, a bit about the background, advising them why it's important, and the fact that they're going to come across it very frequently when they set foot on the ward as an F1 on day 1. When to suspect, coming into the risk factors, the signs and symptoms, including the observations, and then the key investigations that we're going to spend a bit more time on. So the ECGs, the common findings, for example, sinus tachy, and the more specific findings, S1, Q3, T3. The well score, how to interpret, and also the use of the PERC rule, which is quite often used in clinical practice too. The D-dimer, when to use, the sensitivity and the specificity, and how we can use this information to rule in and rule out VTE, and obviously the age adjustments as well. Imaging, so chest X-ray, CTPA, BQ scans, including the benefits and drawbacks for each one. So for example, which sort of demographic of patients are we going to be a bit more hesitant when exposing them to radiation, and which demographics of patients will be perhaps be a bit more liberal and upfront and value the speed rather than anything else. Management, again, A-to-E approach is standard, and we're really going to be ensuring that they understand that. The low molecular weight heparin, the DOAC, and then possibly, if we have time, talking about things like thrombolysis and mechanical thrombectomy, and in which situations you'd opt for that sort of thing. The long-term treatment, including duration, as I mentioned before, is it provoked, is it unprovoked? And then the key safety net and information advice, which our F1, F2 doctors will be delivering on a day-to-day basis, quite possibly in certain areas of the hospital. And then finally, the considerations and the complexity, risk of bleeding, if at what stage to treat, if there is a degree of diagnostic uncertainty. Finally, towards the end of that session, we will hopefully be facilitating some discussion of cases. So the students will be able to manage these cases themselves and decide whether or not to treat them in any one individual situation.
Brilliant. So thank you all so much for listening and for your attention throughout that lengthy talk. We really welcome any questions that you might have, and we're especially keen and we're very, very grateful to hear if anyone has any advice on anything that they might change, or if you have any experience delivering a teaching session such as this, we'd obviously really welcome that before we roll it out. So yeah, just thank you very much again for listening.
Thank you.